Hi, everyone. I think we will get started just in the interest of time. Hopefully everybody can hear me. My name is Nicole Cork, and I'm the Senior Association Manager of iHEA's activities. Welcome to the webinar, Strategic Purchasing for Universal Health Coverage, Theory and Practice, hosted by the iHEA Financing for Universal Health Coverage Special Interest Group. Today's webinar will run for approximately 60 minutes and will be recorded and uploaded on our website afterwards. Before we begin the webinar, I just wanted to run through a couple of housekeeping items. If you experience any technical issues during today's webinar, please write them in the chat box at the bottom of your screen, and I'll be happy to assist. Everyone on the line has been muted except for our presenters in an effort to eliminate background noise. If you have any questions during the webinar, please use the chat box and they'll be addressed by today's speakers. We'll be circulating a survey following the webinar to obtain feedback, so we ask that everyone please take a couple of minutes to fill it out. Thank you again, and I will now hand it over to Virginia Wiseman, today's moderator and convener of the iHEA Financing for Universal Health Coverage Special Interest Group, who will introduce our speakers.
Great, thanks, Nicole. Welcome, everybody. My name is, as mentioned, is Virginia Wiseman. I'm a health economist at the London School of Hygiene and Tropical Medicine, and also at the University of New South Wales. I also am co-convener of the Special Interest Group, Financing for Universal Healthcare Coverage. And it's been a pleasure to work with Elina, who has helped to bring this session together today. And also to coordinate a wonderful selection of speakers. So I'm going to just quickly introduce you to each of the presenters, and then we'll hear their presentations, and at the end there'll be an opportunity to ask questions as well. So our first speaker is Inke Mathauer, Senior Health Financing Specialist at WHO in the Health Financing team, where she's leading the work on strategic purchasing. Her core areas of work include strategic purchasing payment systems, governance arrangements for purchasing, and options to extend health coverage, particularly to people working in the informal sector. Prior to joining WHO 12 years ago, she worked with GIZ, the World Bank, and also the German Development Service in Benin and also in Uganda. Our second speaker today will be Ahmed Khalifa. Ahmed is a health economist, also at WHO, country office in Egypt. He holds an MSc in health economics from Heidelberg University in Germany. His recent work focuses on health financing system review, particularly related to strategic purchasing in the context of a new universal health insurance law in Egypt. Ahmed works on several projects to generate evidence on key health financing indicators to inform and monitor national policies, such as the assessment of financial risk protection indicators, national health accounts, and the costing of hospital and primary healthcare centres. Our third presenter is Dr. Gemini Mtei, is a health economist working as in the finance team, or is the team lead for the Public Sector Systems Strengthening Project, funded by USAID and implemented by Apt Associates in Tanzania. He's coordinating implementation of interventions to improve public financing systems, including strategic purchasing, budgeting, planning, and procurement and financial management to improve service delivery. He has more than 10 years research experience in the areas of healthcare financing service delivery, and has also been actively supporting the government in Tanzania to conduct resource tracking for the past 12 years. And as I mentioned, Elina, who has been bringing this session together so well, I'm sure many of you are familiar. She is a health financing specialist with 10 years of experience in design and implementation of health system strengthening reforms, policy analysis, and research in global health. She joined WHO Geneva in late 2014 as a technical advisor in health financing policy. She, of course, also works very much in the area of strategic purchasing and public financial management. So I would like to tell you more and more about each of our speakers, but that is probably enough time. And I think it's important that we now get on to our presentations. So I'll welcome Inke and Mathauer to kick things off.
So, hello, good afternoon or good morning or good evening, actually, wherever you are. Hello, can you hear me well? Hello?
Yes.
You can hear me. Good. Okay.
Yes, we can. Yes.
Great. And yeah, thank you very much, Virginia, for this nice introduction, and hello to all. It's really a big pleasure for me to be here with you on this important subject of purchasing. Purchasing is not new, but fortunately, in fact, it's regaining more and more interest and attention again by policymakers, researchers, and development partners as well. So here today, I will talk about purchasing health services for universal health coverage, and really about the question of how to make it more strategic. What I will present here is actually based, now how do I? Excuse me, I'm not able to, sorry. I wasn't able to get to the next slide, but here we are. So what I'm presenting is actually based on a WHO health financing policy brief that we just published a few days ago. That is with Elina, Matthew Jowett, Joe Katzin, and myself. This is, in fact, a very short document of just 13 pages with the idea of giving an introduction and a brief overview of the core issues on strategic purchasing. And indeed, one of our target groups are policymakers in countries. So I will be briefly going through the core messages of these 5 sections here. Now, let's start with what is purchasing. I think you're all very familiar with this, so this is more to put us all on the same page in terms of the terminology and the framing. Now, purchasing can be understood as the allocation of pooled funds from healthcare purchases to healthcare providers on behalf of the population for the provision of health services. And I think the aspect of having pooled funds is very important for this notion of purchasing, and especially strategic purchasing as we come to talk about it. We notice that there's sometimes some confusion or some mixing up of healthcare purchasing and procurement, but in fact, procurement of medicines and supplies is not the same. They're related, of course, but they need to be distinguished. Procurement refers to the process of selecting the vendors, establishing payment terms, negotiating contracts for obtaining those commodities in bulk. Now, who are the purchasers, in fact? Initially, one would think of a health insurance agency when one hears of a purchaser, but of course, in most countries, actually, one of the key purchasers is the Ministry of Health, or subnational authorities at provincial or district level, such as a provincial government or local government or district health authorities. Then, of course, the National Health Insurance Agency is a typical example, as well as there are voluntary health insurance agencies in a lot of countries, or community-based health insurance schemes. Could also be an NGO. So indeed, what we see is that there are multiple purchases. Now, the key question about purchasing is how to move from passive purchasing to more active, to strategic purchasing. Strategic purchasing means that the allocation decisions are based on information on the performance of providers and on the health needs of the populations served. So actually what's key here in this definition of strategic purchasing is information, to have information available. And so strategic purchasing is a very active, it's an evidence-based process to define which specific health services to buy from which providers and how to pay for those services and at what rates. And so I think if you look at that definition, I think it's clear that strategic purchasing is relevant for all purchases, including the Ministry of Health. It's not just for a dedicated separate purchasing agency like a health insurance. And we will have afterwards this country illustration from Tanzania by Gemini. And I think this presentation will nicely illustrate that the introduction of strategic purchasing instruments and elements is possible also within the Ministry of Health under core treasury system and public financial management rules. Now, you may have seen this slide. It's quite old. We have been using it quite a lot in the past years. The key point here is really to distinguish this difference between passive and strategic purchasing. And the key difference, in fact, is that strategic purchasing is based on information requires data, and it's also based on making deliberate decisions. So it's about making specific and focused incentives for providers to increase efficiency and quality. It's about being a price and quality maker, so being very active rather than just accepting whatever kind of bills are being sent in from providers, or just making input-based historical allocations without more strategic elements in that allocation. But it's very important, in fact, to realize that passive versus strategic purchasing is not something black and white. It's not, yes, there is strategic purchasing, or no. It's really a continuum. And the key message of this slide here is that countries at all income levels, also at high-income countries, are seeking to progress on this continuum towards more strategic purchasing. It's a continuous process. Strategic purchasing also means to make adjustments on a regular basis to respond to changes, let's say in provider behavior, for example, or to consider new health technologies. And so that's why, in fact, there isn't really a clear endpoint. Strategic purchasing is something that is ongoing. Now, why is strategic purchasing important for universal health coverage? Of course, revenue raising and effective pooling of funds for health are important, but strategic purchasing is vital for countries to be able to really progress towards universal health coverage. I very much like the quote from Joe Katzin, our coordinator at WHO, who says that countries cannot simply spend their way to universal health coverage. The money needs to be spent wisely. And this is exactly where we get to strategic purchasing. Strategic purchasing is the point where budgets are being transformed into effective coverage to achieve universal health coverage objectives. And you also may have seen this graph there that outlines the various UHC intermediate objectives in the middle, here the green ones, and then on the right-hand side, the final universal health coverage goals. And so in fact, strategic purchasing helps to realize efficiency gains, and that in itself then is providing more revenues that can, or triggers more revenues that can be used for the extension of cost coverage or service coverage or population coverage. Strategic purchasing also aims to make the resource distribution more equitable across population groups, across geographical territories, etc. I spoke already about the importance of information, and it's that additional information that contributes to transparency and accountability. And finally, strategic purchasing can help reduce out-of-pocket expenditure through clearer payment methods, through regulation on balance billing, for example, and that then is a way to improve financial protection. So clearly, strategic purchasing is important, is key for universal health coverage. But then the other question is, how feasible is strategic purchasing? Now, numerous countries have made substantial progress towards universal health coverage through improvements in their strategic purchasing arrangements. We also know, of course, that there's still many countries that face political, institutional, and technical challenges. But I think the good news is that, in fact, strategic purchasing reforms don't have to be big bang changes. They can be gradual and they can be packaged. So what you see here in this blue arrow is just an example. It doesn't have to be that order, but I'll just outline that for illustration. The entry point can be to build or to improve the existing information management system. And then as a next step, focus on specifying the benefits and align that with provider payment. then eventually one can focus on improving the payment system to optimize incentives sent to healthcare providers. And then again, as a separate package, one can establish an accreditation system. Of course, these different steps need to be aligned with each other. That is clear. But I think the key point here is that they can be packaged. And also, I think what's important to note is that these changes, these entry points, they are within the realm of the health sector, and they can often be steered by the Ministry of Health or the purchasing agencies. It's not necessarily that all important strategic purchasing reforms have to go to Parliament right away. A lot is taking place at the level of regulatory provisions. But as I said, this is a continuous process. This is an arrow that sort of continues further on the right-hand side. Also because, as said, there are new health technologies, there are new priorities coming up, there are changes in provider behavior, etc. And that requires a continuous adaptation of the purchasing arrangements. So, what does strategic purchasing consist of? Sort of, let's go into the substance. Now, strategic purchasing involves several key areas, or we can say key tasks, that are closely interrelated. So you cannot just work on one of them in an isolated way. They have to be addressed together in an aligned way. So yes, the first key task, key area is to specify the benefits. At the same time, the purchasers need to decide from which providers they actually buy these services, so to select providers. And then third, there is need to design the incentive structure, so the financial and non-financial incentives. So the key policy question with respect to what to buy is, namely, which services, which health interventions and medicines to purchase, and what cost sharing and what referral arrangements are appropriate as conditions of access. So those two sides go together, namely the services as they're covered and the conditions of access, the conditions of accessing those entitlements. With respect to how to buy, the key question is, what are the most appropriate provider payment methods? What type of contractual obligations and other financial or non-financial incentives are available to increase provider performance? And with respect to selecting providers, the question is pretty much straightforward for which providers to buy and how to choose these. Now, in our policy brief, we actually emphasize the importance of information management. And I've mentioned that already a couple of times because this is really key to make strategic decisions. And finally, we also stress the importance of governance for strategic purchasing. Governance is an overarching health system function. It can be defined as ensuring that strategic policy frameworks exist, so a strategy, a vision, a policy, and that this is combined with effective oversight, with regulation on purchasing, with attention to system design. So in other words, really having a system perspective and focusing on ensuring that accountability is achieved. So obviously governance applies to the various health systems building blocks, but of course also to health financing and here in particular to purchasing. And in fact, when we look at countries and their challenges of moving towards more strategic purchasing, we will find that, it's actually the governance arrangements that are critical to make that move happen. And if governance arrangements are weak, moving towards more strategic purchasing is actually quite difficult. So the policy questions with respect to governance are really, first of all, how to exert oversight over a purchasing agency to ensure accountability, to really actually ensure that the purchasing agency is obliged or is induced to operate strategically. And then secondly, at a wider system level, the question is how to coordinate across the multiple purchasing agencies. And the policy question with respect to managing information systems is what information or what data to generate, how best to manage, analyze, and use it for strategic purchasing decisions. Now, in the policy brief, we go into each of these key areas and outline the various policy instruments. For reasons of time, I'm not going into them now, but I have kept the slides for those who are interested to look into it later. I will just highlight a few key points. And in fact, the two following presentations on Egypt and Tanzania will actually further illuminate and illustrate some of these points. But here, I just wanted to highlight a few points when it comes to specifying benefits. I think here it's important to keep in mind that in many cases, the decisions on the benefit design, that's to say the benefits that are covered by the public funds, are made by higher levels of government. And in fact, in a number of countries, you will find that actually this is specified in a law, for example, in a health insurance law. Nonetheless, the purchasing agencies play a pivotal role in further operationalizing these stated benefits within the given budget. So, for example, a purchaser has to take choices and decisions on which specific treatment options for a specific health condition to cover. So let's take the example of dialysis. You know, do they cover hemodialysis or do they actually cover peritoneal dialysis? Or when it comes to medicines, are generics only covered or is it a wider list of medicines covered? And as I referred to already, another important element of specifying benefits is to be clear about the conditions of access, namely about the cost sharing and the referral rules. This one is pretty straightforward. It's really about the question of whether services are provided through public providers and or through private providers and at what levels. And the instruments to use are, for example, selective contracting and accreditation. But we also see that, in fact, the use of selective contracting is rather limited in practice for a variety of reasons. What I really now want to focus on a little bit more is provider payment. In most countries, there are multiple purchasers, so several purchasers, as well as consequently multiple payment methods in place. And so actually what we find is that the payment system is mixed. We have a mixed payment system. And there's a strong need then to ensure that this mixed payment system still sends a coherent set of incentives to providers. And in fact, Ahmed from Egypt, who will come in after me, will nicely illustrate what happens when these incentives are potentially not coherently aligned with each other. So that's really the challenge. It's how to purposefully align the payment methods to set the right incentives to providers. And in the example from Tanzania, we actually hear how, how payment methods can be aligned. Clearly, there's need for regular revision of the payment methods because, in fact, providers at a certain point in time, they understand how the method functions, how the payment methods functions. They will adapt. They will maybe sort of understand how to, go about it, how possibly to play around it. So regular revision and review might be needed. Also, very important is, of course, this needs to go along with a sufficient degree in managerial and financial autonomy of providers, and they also need capacity to go about this additional managerial and financial autonomy. The core message of our policy brief here on strategic purchasing is that information management systems need to be integrated, or at least they need to be interoperable. Now, in a lot of countries, this is in fact not the case. There are frequent problems such as detailed data is not available, it's not granular enough, or in fact, there's lack of harmonized or interlinked data systems, or the several information subsystems actually operate in isolation. And again, just to say, I won't go further into this, but the example from Tanzania will show what the government actually has done to make the information management system more integrated. Just the last point here is, with the digitalization and continuous improvements in information management system, the issue about safeguarding patient privacy becomes, of course, paramount and is extremely important, just as the question of how to guarantee system accountability. Now, with respect to the importance of effective governance arrangements for strategic purchasing, I wanted to highlight and put our attention on the fact that there are two levels. The first level of governance actually relates to the overall healthcare purchasing system. So this is this yellow circle that you can see here, where in fact in lots of countries you would have multiple purchasers operating there, such as the Ministry of Health, a national health insurance scheme, a voluntary health insurance scheme, etc., etc. And so governance of that healthcare purchasing system means to have a clear policy and strategic direction. There must be coordination and alignment ensured across these different purchases, but also beyond, across various stakeholders. And of course, the stewards, the governance actors, so to say, they have to put in place effective legislation and regulation on purchasing. The second level of governance, and that's here the red circle, relates to the governance of a specific purchasing agency. That can be the Ministry of Health or health insurance or any of these other purchasers there. And this governance tries to ensure that this purchasing agency is accountable upwards towards the government, towards, let's say, an oversight body or the supervising ministry, but also is accountable towards beneficiaries and citizens. And so in our brief, we're outlining the various governance arrangements that are needed to induce or to push, so to say, the purchaser to be acting as a strategic purchaser. So there needs to be effective oversight mechanisms in place, meaningful stakeholder participation, clear accountability lines and reporting lines, and above all, a very clear legal mandate that the purchaser is supposed to operate as a strategic purchaser. Likewise, empowerment of citizens and patients is extremely important. They need to be informed about their rights and entitlements, and there must be functional feedback channels and complaints mechanism in place. In our health financing policy briefs, we always have a very strong interest in illuminating the alignment issues between the various health financing functions. So here in this brief, we have a table that explores the alignment issues between strategic purchasing and what you see here on the left-hand side, revenue raising, pooling, public financial management, service delivery, and devolution. I don't want to go into this, but just to say that it's there for those who are interested. And more importantly, to say that there are ways to address these alignment issues. And here's my final slide. I wanted to just summarize with the WHO perspective and some key messages. So I think it should have become clear that indeed there are a range of strategic purchasing measures and policy options. There are many entry points and countries can apply these. Of course, this requires capacity to introduce these changes and to then implement and manage the implementations. At the same time, there's need for having a system perspective. As policymakers who are in charge of governing the overall healthcare purchasing market, there's need to have that system perspective. It doesn't help to try to optimize a specific scheme only. Now, it's also clear that there are multiple issues calling for reform in health financing, and so that raises the question of how to sequence health financing reform for successful implementation to move towards towards universal health coverage. And in fact, the experience suggests that getting the incentives right for provider payment and for service provision is essential and should happen before actually one tries to pull in more money through revenue-raising reforms. Fourth, strategic purchasing reforms are often technical. As said, the changes do not always need approval by parliament or higher level legislation. A lot can happen at the level of regulatory provisions. But of course, we should not forget that there is a political economy behind these technical issues, let's say, of payment methods and rates. Of course, as strategic purchasing changes the allocation of funds, there are strong interests behind. And so the political and the institutional feasibility must be understood and must be well addressed. And that, again, brings us back to the issue of the importance of effective governance arrangements. Without effective governance arrangements, it will be difficult to move towards strategic purchasing. And with that, I will finish just to say we have a couple of new WHO guidance material that can help to assess various aspects, such as a mixed provider payment system, or the second one here on the left-hand side, the governance for strategic purchasing. And with that one, I thank you very much for your attention, and I'll hand over to you. Thank you.
Thank you, Inke. I think that that's been a really useful introduction to strategic purchasing and provides a really nice platform to then move into our two-country case studies. We've got Ahmed now to present on Egypt. If there are any sort of points of clarification, I think Inke would be happy to take those now. Otherwise, we would probably encourage people to hold their questions to the end.
Hello, I'm Rajasalochana from India. So it was a beautiful presentation on, introduction to strategic purchasing. I would like to know some of the key WHO message, especially Strategic purchasing, you said that it involves technical issues and the political economy. So could you please highlight, could you please elaborate on what does those technical issues are and what kind of political economy underlies such a technical issue? Thank you.
Okay, let me just briefly answer that. So let's say the question of determining the mix of payment methods, the payment rates. Initially, this is a technical discussion. You need experts to look at the various issues. It's a technical discussion. But of course, this means changes in payment methods and in rates mean that, providers will earn more or will earn less. Now, I'm talking of provider as a facility, not of an individual health worker who is most often employed as a staff, but this is especially relevant for private providers, but also for a public facility, because at the end of the day, it matters of how much they actually get through, payment methods. So it's initially a technical issue, but then it becomes a political economy issue because there are interests behind. So let's say in a lot of countries, you would find that the Association of Private Providers is very strong in negotiating with the National Purchasing Agency to get higher rates. So this is a political economy issue. On the other hand, another issue is, let's say, specific patients associations would want a certain benefit or a certain treatment to be covered. So they would lobby, which is, their perfect and their legitimate right. But these are the different interests behind that come into strategic purchasing. Maybe just briefly as that to illustrate a bit what are the issues behind. Thank you.
Thank you so much.
Thank you. Excellent question. Any other points of clarification before we move on? No? Okay, well, over to you now, Ahmed.
Well, thank you very much, and thanks to everyone for joining this webinar. I'm very pleased to be presenting to you and to be here with you. So in this presentation, I would like to discuss what we think could be some of the impacts of implementing the new universal health insurance law in Egypt, with the special focus on key issues related to strategic purchasing and relevant governance arrangements in the purchasing market. So before I start, I would like also to briefly acknowledge that this presentation is based on a report that was jointly prepared by WHO colleagues, Inke, Mathauer, and Mtei, and myself, and also received comments from the WHO country office team and colleagues from the Egyptian government. And in this report, the main aim was to proactively anticipate the strength and possible challenges of the new law, and also to develop options on the payment system, as well as on the related governance arrangements of the purchasing market. So just to get everyone familiar with the situation in Egypt. So last year, Egypt has endorsed a new health insurance law, which is considered by many as a great achievement, and everybody here is hoping that this will address many of the long-standing health system challenges in Egypt. So according to this law, all Egyptians will be covered on compulsory basis through family membership, and the state will subsidize the poor and the vulnerable population through budget transfers. Now, this law will be based on separating the funding from provision of service. And for this, it creates 3 new organizations, which I will discuss in details in the next few slides. Services under this new law, which are mostly curative services, will be covered by the newly created single-payer agency, whereas the preventive services will be funded differently through the Ministry of Health. And these services, the curative ones that are covered by the health insurance, are going to be delivered on competitive basis between both the public and the private market. Now, this law will be implemented incrementally, starting from this year and over a period of 15 years on geographical basis, which means that during the implementation period, both the old and the new system with its organizations and structures will have to coexist. And this, of course, may create some coordination and transaction costs, and also could affect the behaviors of both providers and patients during the course of implementation. So the first step of the assessment was to map the purchasers and providers market and the payment methods. And of course, you know that this is not always an easy task, especially in very fragmented systems. But without getting into too much details about the situation, so just to let you know that the current system is largely financed through out-of-pocket payments. And the second thing is that to let you know that the purchasing market as well as the providers market is very, very well fragmented. And of course, this is something that reduces the redistributive capacity of the current system and the purchasing power, and also raises the administrative cost for the whole system. And then the flow of funds between the purchasers and the provider is very complex, to say the least. And so, as you can see, the providers receive multiple payments from different sources with different methods and rates that could be very much incoherent and mostly contradictory. And so what the new law is trying to do is that it tries to simplify the purchaser and provider market by merging those multiple public payers into one in order to reduce the fragmentation and inefficiencies, and also to introduce a more coherent set of incentives into the payment system. And so over time, we will end up having something like that, which can be considered much more simpler. You will have one organization as a single payer for this new system, the curative services. But we also have other purchasers, important purchasers, such as the Ministry of Health, which will be funding the preventive services, and also the Ministry of Higher Education, for example, which will be funding the university hospitals. And so the mixed payment system will continue to prevail. And that's what brings me to the next slide, in which we want to assess the incentives created by this new mixed payment system and their influence on the provider behavior and also on UHC objectives. And so here I will give you, I'll just show you one of the examples, which is about the primary healthcare. Now, the primary healthcare in the new system will be reorganized to be the entry point or act as the gatekeeper for the whole system. And this PHC will provide a package of care that will consist of both preventive and curative services. And currently here in Egypt, there is an ongoing debate on who should pay for preventive care. Is it the ministry or the new insurance? And of course, this is a very important question. But we think what is an equally important question is how you would pay for this preventive services. So as per the law, the curative services will be covered by the new health insurance through mostly output-based payment, while the preventive care will be still be funded and paid for by the Ministry of Health through input-based payment methods such as line item budgets. And so as the same health facility, and in fact, the same providers, the doctors or the medical practitioners, will provide both curative and preventive services. So, and also they'll be receiving two different funding streams with two different methods. And so there is a risk that this can develop an undesirable provider behavior, which we all call resource shifting, by shifting resources, attention and staff time and resources towards curative care. And this, of course, can affect the preventive care and leads to resource shortages on the preventive side. And this, of course, may have also wider implications on the UHC objectives on efficiency, for example, since most of the population may not get the prevention that they need. And also this may affect the quality of the preventive services, since shifting these resources and time and attention of the medical practitioners could affect the quality of the preventive services that are provided. Now, let me give you an overview of the governance of the purchasing market, and to see the institutional arrangements of which organization does what, and also the accountability lines in the new system. So as mentioned before, the new system creates three new organizations. One is the Universal Health Insurance Organization at the left, which is actually the payer, the single payer, and it will be under the general supervision of the Prime Minister. And then we will have also a healthcare organization, which is the public provider, and it falls under general supervision of the Minister of Health. And then finally, an accreditation organization, which falls under the President of the Republic of Egypt. And its main function is to set the accreditation criteria that has to be fulfilled before contracting takes place between the purchaser and the provider. Now, it's very important to note that the decision-making power across the three organizations stems from its board of directors. So across all organizations, the board of members is the supreme authority that is in charge of implementing its policies and without the need to be approved by any other body, which is of course a very positive thing that gives great autonomy to these organizations. And then the law was very detailed and prescriptive on the multiple accountability lines that is aimed at balancing the increased level of autonomy of all three new organizations. Now, so what am I saying all of this, and what's my point here? We think that the governance structure of the new system was very detailed and the oversight structure was very clear. However, what is not so clear to us is the role of the Ministry of Health within this framework. So while the Ministry of Health will still maintain its role as the main regulator of the national health policies, it's very unclear how the Ministry of Health will undertake such role and with which instruments. So as I just mentioned, while the Ministry of Health is still the general supervisor, for example, of the public provider, all decisions are made by the independent board members. And across the three organizations, the representation of the Ministry of Health is just one seat or one vote across the whole organizations. And in this situation, we think that problems may happen when the national health policies that are set by the Ministry of Health contradict or are not in compliance with the newly established organization's individual directions. So for example, the new healthcare organization, which is actually competing with the private sector for providing the services, may develop what we call a profit maximization behavior by focusing on providing more profitable curative services as opposed to a national policy that focuses, for example, on early detection. And this is what we think may create some problems in the near future. And so now that I just give a brief overview on the governance structure, let me put forward this example to you. So currently in Egypt, we have a situation where Egypt is unfortunately the third highest country in the world in terms of C-section deliveries. And this is of course quite alarming. So now the question is, given the new governance arrangements, who should address this national health situation and how? And so to answer this question, usually what other countries do is that they use a mix of measures, right? That includes rules and regulations to enforce, for example, treatment protocols or clinical guidelines, but also they use incentives that are created by the payment methods or the pricing system to influence the provider's behavior towards a certain policy objectives that is set by the principal regulator. And this second part is what we think is missing in the new system. So while the Ministry of Health currently and in the future will still have all the authority to initiate, for example, decrees or laws, it have minimal influence on decisions related to pricing, to benefit package design, to payment methods. And we think that these decisions, and I think most of you would agree with me, should not be just regarded as technical exercises. It should be also in compliance with the national health priorities of the country. And so to answer who should address this problem or national health situation, we think, well, all three organizations and the Ministry of Health could do something, but there should be a higher coordinating body to steer the market across all these players. And so at the end, we developed, we proposed some of the options to the government to be taken forward on the short, medium, and long term. And here are just some of the examples of the options that we provided in the report. So the procedures for determining and reviewing the provided payment methods and benefit package was not clearly specified as per the regulations. And this is something that we need to explicitly specify. And there's also a very important point to align the funding streams for preventive care and for curative care, to send the right incentives to the providers in order to avoid distortions that could happen in the example that I showed to you in the PHC. And then we also understand that this could be not feasible in the short term because the Ministry of Health is still under the restrictions of the public financial management rules. And so in this case, we may suggest to add, for example, a performance component to give incentives to the providers, for example, to give more emphasis on preventive services. But also other option, which could be on the medium or the long term, is to propose to consider through the law or the bylaws or executive regulations that to make the distinction between the personal and population-based services rather than curative and preventive services, where all personal-based services, whether preventive or curative, could be paid by one organization, and then the population-based services could be paid by the other, the Ministry of Health, for example. And this would make it much more easier in terms of implementation. And then finally, to make sure that the strategic purchasing decisions are in compliance with the national health policies, we suggest to strengthen the role of the Ministry of Health in the new framework. We also propose to establish a new national high-level commission, preferably chaired by the Ministry of Health, for coordination and mediation across the three organizations and to steer the purchasing market towards its intended objectives. And finally, we think also that the implementation plan over the 15 years is a bit long, so we have to keep a close eye on the implementation process and to assess its implication over time and to consider transitional solutions where appropriate. Now, thank you very much. And in the end, I would like just to say that perhaps the report will be available online next week or the week after. So I invite you all to in case you're interested, you can go and see more details about this. Thank you very much for your attention. Thank you.
Thank you very much, Ahmed. I wonder if there are any pressing questions. We're a little short on time, but if there are any points of clarification, otherwise we can have questions at the end. Okay, well, maybe we'll move on now to the next country case study, which is Tanzania. So thank you, Ahmed. And now it's over to Gemini. Thank you.
Okay, thank you very much, Elina. Hello, hope you can hear me. So I'm going to give a quick overview of how Tanzania has initiated the move to improve strategic purchasing. And today I'll talk a bit about the health facility, direct health facility financing. So as an introduction, Tanzania, the vision of Tanzania is at least to achieve universal health coverage, like most of the countries aim to do that. And the system currently, the financing system is highly fragmented with a lot of funding sources that are flowing in different mechanisms to service provider. This is a similar problem to what Egypt is trying to address through a unified mandatory health insurance. So we have the general domestic tax, we have the development partners who are supporting our budget. We also have development partners who are specifically supporting the budget for health. We also have some of the regions that are receiving result-based financing. We have also the vertical programs, but also small proportion of health insurance for formal sector and the informal sector. And also without forgetting, we still have a user fee in the system as well. And as I said, the long-term vision of Tanzania is to achieve universal health coverage through the mandatory national health insurance, a same process or approach that Egypt is taking. But achieving this universal coverage through mandatory health insurance will require resource addition, especially to fund the poor, and it also requires some political dialogues that are currently ongoing. But it is a long-term vision but the country has decided to continue with the step-by-step implementation process. And the first entry point that the country thought is very necessary or very crucial is the improvement of purchasing through the aligning of the health financing and the public financial management. And direct health facility financing, to us, we see this as a good shift toward output-based payment system. And this is a key reform that introduces some sort of autonomy and also makes providers visible, which is very important when we want to improve strategic purchasing. So this is just a quick pictorial demonstration of the long-term vision, is to have a single purchaser, but also a clear minimum benefit package that will be defined as an entitlement to every citizen, but at the same time address some of the financial management aspect at the service provider level. And this is the step-by-step improvement. So we are starting with the harmonization of provider payment mechanism. At least with these fragmented sources, we are trying to do things better for each fund sources. So we're starting with the part which is part of the core government financing, which is the Health Basket Fund, but also improvement in relation to Community Health Fund. And at the same time, we have the result-based financing, which is already implemented in some of the regions, as I said. So direct health facility financing to Tanzania, we see this is a key step for the preparation of the establishment of this universal health insurance. And it includes the flow of funds directly to the service provider, specifically for the Health Basket Fund. This is the money that is flowing through the exchequer system, the treasury system, through the Ministry of Finance. But also it includes improvement in relation to specific health insurance schemes. We have the Community Health Fund that was used to be managed by the district councils, and it was treated similar like any government fund that is flowing at that level. And then some of the improvement has now started to be initiated in the National Health Insurance Fund. And for all this direct facility financing, we are adapting formula-based allocation to service provider, at least starting slowly to move away from the line item budget allocation to the service provider. And this is an improvement to the old system, whereby all the funding were flowing to the districts, and the districts were responsible to buy inputs, and they were supplying these inputs as in kind to the service provider. So this was kind of a passive purchasing. And we see this is a major improvement to give a room for the service providers to better match resources that they get to priority services. Because initially they were waiting for the input to come so that they can deliver service. But for now, the money will be in their bank account and they'll be able to prioritize based on the community needs. But also it's more about predictability of funds. It's a formula-based allocation, so at least facilities will be able to determine the amount of money that is flowing to their bank accounts quarterly or monthly. But it also is a step-by-step introduction of facility autonomy, which is very important, as Inke mentioned in her presentation before. So it's more of a facility autonomy to plan, budget, and procure input based on the priorities that they've identified. But also, it enforces accountability into the system, because it was very difficult to tell the providers to be accountable if they don't have resources to deliver services. So in other ways, it was very difficult to meet the expectation of the population because the resources were not in there. So it's a unified provider payment mechanism that we are following up, improving the payment for each fund source. So both Health Basket Fund, which is the money that is flowing through the exchequer system, and the Community Health Fund, which is the money now is being pulled at the regional level, they're both using capitation payment with some adjusters. And as I said, this is already a shift from the input-based budget allocation to output-based provider payment. And with this kind of movement, what we can say, and a good experience that we can share to other countries, is the aspect of introducing output-based payment under the Health Basket Fund, which is flowing through the exchequer system or through the Ministry of Finance, is a proof that we can gradually introduce strategic purchasing under the core central budget system. So just a little bit in terms of how we allocate the funds to the service providers. So under the Health Basket Fund, we have 3 adjusters. We use the adjuster for need, and this is proxed by the service population, like the people around the facilities. But we also have an adjuster for performance, and this we are proxying it using total facility outpatient visits. And then we have a measure of adjuster for equity, which is measured by the remoteness, the distance where the facilities are located to the center of the councils. And it's a similar formula that has been adjusted to the community health fund, whereby we are using the service population similar to the allocation of this health basket fund, but also we are using utilization for among the CHF member, but also the proportion of members who have enrolled to a CHF. At least this is the last 2 adjusters is to make sure like we encourage quality improvement at the service provider level so that members can continue using services there, but also we want to give the providers also a space to motivate for people to enroll to health insurance. And over time, we expect this improved payment modalities to be now adapted to other fund flow, including the National Health Insurance Fund, which is currently under the process of reforming or improving their payment system, especially for primary care, to align with the payment modality under health basket funding and the community health fund. So when we are talking about extending strategic purchasing, and especially when we are touching some of the co-funding that are flowing through the exchequer system, it is very important to make sure that the system, the core PFM systems that are used to manage planning and budget together with financial reporting are also extended to the service provider. But also it is important for these systems that are extended to the service provider to communicate to each other. This is the point that also Inke insisted. So for Tanzania, for the local government authorities, because we're following a decentralized system, we have a planning and budget system called PlanRep. So initially this system was ending at the district level. So all plans and budgets were ending there and all the inputs were procured at that level. But with the DFF, with the DHFF, there was a need now of extending the system. First, we converted this, which used to be a desktop version of the PlanRep into a web-based planning and budgeting system. And to a large extent, this improved efficiency in terms of preparation of the plans, but also the review process, which to a large extent, most of the Ministry of Finance cares a lot. Without building confidence where, like, say, the money that is flowing is going to be used and planned better, it is always a challenge to implement this kind of strategic improvement reforms that touch some of the core PFM systems. And then we introduce the service providers into the chart of account. So at least for now, we have more than 5,000 health facilities. So at least all individual health facilities are now showing up under the chart of account. And all of them will start receiving ceilings during the planning cycle. But also the other improvement that we did through this planning system is the introduction of the service outputs. And this is a gradual now step toward output-based budgeting. At least the health sector and its department should be able to report what kind of services they are providing to people with the money that is available. And the most important things that I also mentioned is interoperability. This planning and budgeting system is now interoperable or integrated with the financial management system. And this, to a large extent, to the people who care more about the PFM, is a room for performance audit. And all these changes, as I said, involved some of the improvement in the chart of account. The other system that we managed to extend to the service provider is a financial management system. So initially, there was no system for facilities to report on how they use funds. And if you're introducing this kind of a major reform of now starting disbursing funds directly to service provider, it is very important to have a concrete financial management system so that you can report back on how the money is being spent. And it is a system that has been developed following standard accounting procedures, but it is a bit simple. It is customized based on the understanding that it's difficult for the service providers to manage complicated financial management system. And again, it is interoperable with the plan rep. So I just want to insist on this last bullet, that it is very important to have a sound financial management system at the service provider when we negotiate improvement in strategic purchasing in the central budget systems. There are other systems that have also been extended to the service provider, and especially looking on the aspect of future improvement of the payment system. We need to have good information that will help us to design a provider payment system. So for Tanzania, we have this Government of Tanzania Health Operation Management Information System. This is a unified patient management information that is going to be used across all public facilities. And starting from a dispensary up to the regional hospital, and slowly that will also go to the higher level referral hospitals. It is customized according to the size or capacity of the facilities. So like the dispensary will have a simplified module within the system, the health centers a bit advanced, and the hospitals in that order. And it is a system that has been currently being integrated with the National Health Insurance Fund claim management system. And also this system has also been integrated with the health management information system. I'm sure most of you guys will be familiar with the DHIS2. So this patient management information system is now integrated to this health management information system. And to a large extent, it's improving the quality of data, but it provides data that will inform future improvement when we design the provider payment systems, and especially the provider payment system at the hospital level. To have, for example, a good DRG, you need to get very well and good information, the patient information, to develop that kind of improved systems. But we also have the GoToHome is integrated with medical store department electronic logistic management information system. So to a large extent, there have been a lot of cries, especially for the facilities that are located in remote areas, in terms of availability of medicine and medical supplies. And one of the constraints was having the right information in time for the central medical store to be able to organize procurement centrally and also disburse or predict needs across the facilities. With this kind of integration now, the medical store department can easily follow how the facilities are consuming medicine and medical supplies, and they get ready to procure according to expected demands that are going to emerge across the facility. So to a large extent, it's an improvement on the supply chain. So why I'm talking about this, what we want to say here, while we're talking about improving strategic purchasing, it is important to create an incentive that will provide space for the providers to improve service delivery, especially the quality of service that they deliver. And with that aspect, we need to go beyond that and look at what are the enablers at the facility level to make sure they really use the opportunity of improved provider payment mechanism to actually deliver the service that we require. So this is just a summary of before and after the DHFF. On the right side, left side of my screen, this was before, where, as I said, funds were ending at the council and they procure inputs and then they supply inputs. And sometimes this was really a push. Facilities were receiving some of the medicines sometimes that they don't need, some of the supplies that they don't need. At the end, it was like really a big frustration. But with the improved system, now the funds are flowing to facility bank accounts straight. And then we have the financial management system on top of that, and the patient management information systems. At least this is simplifying a little bit the work to the service providers. So as a conclusion, what we are saying is moving towards universal coverage requires step-by-step improvement. Especially, it is important to start with the things that are easy to implement. So to us, we thought it's okay. If we enter through efficiency gain and improving purchasing, that is really a major gain. And for Tanzania, just to repeat and insist the point that it is not always true that you cannot introduce improved or strategic purchasing under the core budget system. It is possible. It all need alignment between the financing and the financial management system to be able to move forward with this kind of improvement. So with this, I'll end here. I know the time is up, and over to you, Elina. Thank you.
Thank you very much, Gemini. It's Virginia here again. Thank you. We've just had 3 excellent presentations. I wonder, Elina or any of the team, if you wanted to add any comments at this point, or we just turn it over to the audience for any comments or questions.
Hello?
Yes.
Hi, I'm not sure if you can hear me well. Unfortunately, I lost my voice. So, but I just wanted to actually, it's a question and a remark before it's in both of these countries, it seems strategic purchasing and changes in provider payment methods were one of the, let's say, key steps in moving towards UHC. And in Tanzania, it was more of a, let's say, a practical step without even having, they haven't been able even to pass the big changes in health insurance coverage and entitlement, but they're moving it towards that harmonization in a more practical manner. And I think that's a very interesting lesson. And I wonder if Gemini can say, how generalizable do you think is this, the experience of Tanzania for other countries in the region? And for Ahmed, I also wanted to find out, because he seemed to be very concerned about the implications of new mixed payment systems for the preventive care. But I think from as much as we understand about quality of care and it's not the financing or the payment is only one part of it. And you can do a lot through supervision, through contract, through indicators that are in the performance contracts. And I wondered if they were envisioning some sort of contracts with providers where there would be preventive care indicators of performance that would include preventive care, so that even if their payments are not explicitly linked to preventive care and they're based on input-based line items, that the providers would still feel they have to be responsible for certain, at least key services, preventive services. And I know we did that in Kyrgyzstan, and it was, I think, one of the successful experiences. Thank you.
Okay, thank you I'll go first, Virginia, if it's okay. So how generalizable is this for other countries across the region? I think I would say it is possible to apply this kind of improvements to other countries. And this is because we have a lot of similarities, especially in the core PFM structure across the neighbor countries. And I'll start with that improvement that we managed to do through the house basket funding that is flowing through the treasury system. I think the important thing is we need to understand what are the expectations of the other side. We are going to create a deal with the Minister of Finance to change the way the budget formulation and execution and monitoring is being implemented. And for that, it is important to create confidence. And at the service provider level, I'm sure everybody cares about better use of resources. So what we thought is very important, we need to start by establishing a good financial management system at the service providers. It's a simple, but it's a requirement or it's a need for any fund flow that is flowing there, whether it's insurance or it is general fund, general budget. So that to us was really an important thing. Establish a good financial management system there. And you can start, know there are difficulties in terms of connectivity. So we started with the manual system where we have the standardized template that will be used across all fund sources. And the facilities are using this. But those who have good connection, they moved straight away to the electronic system. But for those who are using like a manual system, they will feel that, but go to a nearby facility or a district where they will get good connection and enter that kind of information into the electronic system for report generation. So it is possible to start that way. And also, it is now, after doing that, we go and strike a deal with the Minister of Finance, like showing we are ready to do that. And what information they need, you need to commit that you are able to provide that information. So with that kind of negotiations, that bring the government, but also some of the development partners who are also supporting the health budget. It was a kind of a negotiation that brought us to this level. And it's also important because here there is a big role for the technical teams. The technocrats have to sit down and think better, at least on what is the provider payment system that will be good for the service providers. And so that's where we started discussing like how we can develop the capitation, make it simple, to address the equity and the performance. So there is a room of the technical capacity to be able to advise the people who are working with the government, the Minister of Health, but also we have a very strong local government ministry. So all these counterparts need to sit together and see a value of this. So I would say it's generalizable, but the extent or the magnitude of implementation, it has to go step by step, and it also depends on how the countries are. So that's how I would think. Thank you.
Well, thank you, Elina, for your question. Well, of course, I agree with you on the importance of other measures, such as the quality enforcement or improvement and the performance contracts for the prevention. And this is exactly our point. The point is that we're saying that these measures should go hand in hand with setting the incentives right, in order to have our objective for improving prevention as well as curative services. So, and maybe this was the message we also end by in the slide on the governance structure and the role of the Ministry of Health, that both measures, whether on quality, on treatment protocols, and also on the setting the incentives through strategic purchasing tools, should go hand in hand, well, complementary to each other's. So I just couldn't agree more with what you've just said.
Could I also just add on that point about Egypt? So I think we all agree that accompanying measures are needed, and there's a role for contracts that set out potential performance targets and a role for supervision. I think that the issue that Ahmed presented is that through the new system, through the changes in payment rates, there is a stronger incentive for providers to shift resources towards the patients and towards the services that are financially more attractive. So that's the curative services that are paid through the health insurance organization, whereas preventive care being funded through line item budget allocations for the Ministry of Health gets even less incentives for, or comes along with less incentives for providers to focus on. I mean, we all know that providers often have a preference to focus more on curative care, but through the new payment systems, the difference in the incentives between the two funding flows is even larger. And so, yes, of course, we need accompanying measures, but I think we also have to look at the cause of resource shifting and really try to align payment methods. Now, this is for the case of Egypt, but for so many other countries, because only through accompanying measures, it will be difficult to overcome, strong incentives for resource shifting, for patient cream skimming. So yes, I think we also have to look at the cause of the issue, which is the mixed and messy payment methods, and there's need to address that at the cause, at the root, and hence align those payment methods. So thanks, just wanted to add that. Over.
No, thank you, Elina, for your question. Were there any other, I don't know if any of the other speakers are getting any questions in the chat room. If people would like to either ask a question or they can also add a question. I think there are a few coming up. Yeah, there's quite a few. Would the speakers like to select any of the questions that are starting to appear here in the chat group?
I'm sorry, I don't see those questions in the chat room. Can you just read some of them out, please?
There's none right now.
Oh, sorry, Nicole. I'm seeing the comments there amongst the speakers. My apologies, Inke. So, are there any questions from the audience?
Yeah, I have a question.
Go ahead.
Hello. Okay.
Yes.
This is Ucheberi from Nigeria. So I have a few questions for Ahmed and just one for Germany. I'm interested to know, with the universal health insurance scheme in their country, was there an additional budget line to cater for the universal health insurance scheme to ensure that the already allocated resources for Ministry of Health is not tampered with? That is one. Also, why do they have to create another healthcare organization in addition to other public health facilities that are already existing that could also offer these services? So it's not clear why that is important, why they created that. Then with the inclusion or with the specification of free services for the indigent and vulnerable groups, how do you identify those people and how do you ensure transparency in offering services to those people? Then with so yes, with double funding or multiple stream of funding at the facility level, so from the preventive and curative aspects, how do you manage to make sure, I mean, a lot of people have already alluded to that, how do you manage to make sure that, to mitigate resource shifting and also ensure that the resources are used for the right purposes? On the issue of alignment, I mean, Ahmed, you had already said that one of your recommendations is for funding, the preventive and curative funding, to be aligned down to the facility level, which is a good suggestion. Now, my question is, for that to happen, the law has to be amended, right? So how long will it take for the law to be amended before to facilitate implementation of this alignment when it comes to funding at that facility level? And how long with this, or what implications will the duration have on the implementation of universal health insurance in your country? Then for Gemini, so you had mentioned that the whole essence of the direct facility funding in Tanzania is to ensure delivery of services, especially quality, delivery of quality services. Now, how do you measure quality services? So this also alludes to what Elina had earlier said, that do you have indicators to make sure that you measure people or you measure service providers against these indicators? Or what are your mechanisms to ensure this quality of services, so that at the end of the program or while you're implementing this program, you can periodically assess what is being done and to ensure that the whole essence and the goal is being met? Thank you.
Okay, thank you so much for all these questions. So let me just give you a brief answers in the interest of time. So in terms of the first question, which was about how did they allocate resources for the new system in order not to get into the same problem of the current system. So the new system is also based on a credible financial constraint, as we understand, and the law was not passed in the parliament until the point that they provided an actuarial study that proved that this system will be financially sustainable over 15 years, and also in this study the new system will be based on a diversified funding sources for the contributions, in addition to budget transfers and other resources such as, for example, indirect taxations and tobacco taxations, and so many revenue sources, in order to make sure that we predominantly rely on public sources of financing. Now, on the issue of mitigating the resource shifting by aligning the funding, and this could take some time, and I agree with you also. And we put this in our report as a long-term goal to make the distinction between services, personal versus population-based. And we understand that this may take some time through executive regulations and amendment. And so for the short term, we can also having the same funding flows, we can add, for example, also complementary to other measures, a performance component for the in order to incentivize providers to put more emphasis on preventive services, and so this is one of the short-term measures that we can make. Now, for the targeting criteria for those who are not who will not be able to pay contributions for the system, that will be based on existing databases in Egypt right now, in addition to other proxy means testing and other criteria that are being developed at the moment. So I don't have clear-cut answer on this, because this is something that is being under development, and hopefully before the end of before the start of the implementation, these things will be clarified to everyone. But at the moment, we don't have a clear answer on the criteria for targeting the poor and the vulnerable. Thank you, and over to Gemini.
Okay, thank you, Uche, for the question. So I'll go direct to this question of quality. So first of all, I should say this is the improvement that we are currently doing is not a program. So it's the whole system improvement. So we're really applying this across all fund sources that are currently existing, and it applies across all facilities in the country. And it's also some of this introducing within the core financing, the Ministry of Finance budget. So it's the system change rather than just a program. And when we were starting in this discussion on how we can really introduce a simple formula, we thought of a simple performance measure. And to us, we decided to take total utilization as a proxy of facility, with assumption of performance, with assumption that if a facility is really improving quality, and in this, what we measure as quality, we're looking more on availability of medicine and medical equipment. These are the things that will attract patients to use, but also the time that the service providers are spending and see patients at the service provider level. So these are some of the things, the quality in terms of the cleanness of the facility, availability of utilities, water at the facility level. So things that, for example, will really make sure pregnant women are delivering in a good condition and very clean environment. So these were the things that we were foreseeing as the system, some of the system measures of quality. And that's why we decided to proxy the performance in our capitation formula using total facilitated patient visit, because these are the things that will really motivate patients use. But some of the broad range of other quality measures that are program-based, like the result-based financing, similar to many other countries, the design is usually similar. They have some of the performance indicators that they have integrated into that modality, and they pay these incentives based on the performance of facility on this. But we didn't take that RBF approach where we just limit facilities to focus only on a few indicators, but rather we thought of giving a space to the service providers to really think about the things that matter, to encourage use of service, but also to be able to deliver the service that is coming from the population. Thank you.
Thank you. I realise that we're well over time, but and obviously people who need to go, may need to tune out. But if there are any remaining questions and the speakers are happy to stay on, then please do raise those questions. Any further questions from the audience, the participants? No? Okay. Well, I think the speakers would be more than happy if you do have any questions that come to mind after today's presentations, then I don't think there'd be any problem in contacting them for further questions or clarifications. I would like to say on behalf of the Special Interest Group, we'd like to thank each of our speakers and also to Elina for, even though she's not been well, for helping to organise this session, and to Nicole. Were there any final comments from any of the speakers?
Just to say thank you very much for having been able to participate. It has been a real pleasure. I look forward, as Virginia says, if there are any questions, please do not hesitate and get in contact with us. And thanks again.
Okay. All right. Wonderful. Thank you, everybody. Nicole, did you have any final points to make?
No.
No? Okay then. Well, thanks very much, everybody. And as Nicole mentioned earlier, there will be, the webinar has been recorded, and feel free to alert your colleagues to that. And we'll be in touch soon with information about our upcoming webinars for this special interest group. Thank you so much.
Thank you, Virginia. And thank you, everybody.
Yeah,
Thank
thank you, everyone. Thanks.
Bye.
Bye-bye. Have a good day.
Mhm.
Bye-bye.